Is it hand osteoarthritis? Hand OA. Okay. This patient has osteoarthritis at the first carpometacarpal joint, and osteoarthritis presents with chronic progressive stiffness and pain that worsens when working with tools and performing fine motor works. Risk factors include age more than 40, repetitive joint stress, diabetes mellitus, and excessive alcohol intake. Examination typically shows heart periarticular enlargement, crepitus with movement, and mild tenderness. Other affected joints include distal interphalangeal and proximal interphalangeal, where bony enlargement classically manifests as Heberden and Boucher's node. X-ray reveals decreased joint space, subchondral sclerosis, and periarticular osteophytes. Periarticular osteophytes. Okay. Okay. Look at the box first. Acute back pain, less than 4 to 6 weeks, without a history of trauma. Significant neurologic deficit. In here, what significant neurologic deficit is present? Urinary retention or incontinence, saddle anesthesia, lower limb weakness involving multiple nerve roots or root compression. Lower limb weakness involving multiple nerve roots, yes. Emergency MRI, no. Suspected infection, fever, spinal tenderness, IV drug abuse or immunosuppression, yes. MRI or consider X-ray with or without ESN, no. Suspected malignancy, current or cancer history, symmetric symptoms, weight loss, multiple cancer risk factor, yes. MRI with or with ESR or CRP, no. Uncomplicated back pain, no imaging needed, continue pain management. Most cases acute, less than 4 weeks. Low back pain have benign etiology, resolved spontaneously. Imaging generally does not improve the outcome and is not recommended. Spinal imaging is indicated for patients with significant neurologic deficit and red flag features. Red flag features like consider a high risk feature in back pain. Consider MRI if any of the following is present: Cordai-Kuhner syndrome, acute urinary retention, saddle anesthesia, epidural abscess, fever, immunosuppression, IV diagnosis, malignancy, and other. Severe bilateral progressive focal spinal tenderness, coagulopathy, and age more than 50. This patient has features that raise her concern of malignant back pain, including nocturnal pain and history of malignancy. She has a history of malignancy.
Yeah, she had breast cancer.
She warrants imaging despite unremarkable neurologic examination, given the urgency in treating metastatic or bony lesion. The preferred test is spinal MRI, which is high sensitivity for lytic bone lesion and metastasis in the surrounding soft tissue. If MRI cannot be performed, CT scan has a good sensitivity for bony disruption and is reasonable alternate test. Plain firm X-ray have lower sensitivity for bone metastasis, but some guidelines suggest X-ray combined with inflammatory markers, ESR CRP, to increase the sensitivity for patients with moderate clinical suspicion for malignancy.
Balance, balance, balance.
Isolated ALP, age more than 75, 70. What is your diagnosis?
Is it metastatic?
And the complication is high output cardiac failure and osteoporosis. Okay. Alkaline phosphatase is a ubiquitous it's a ubiquitous enzyme that has its highest expression in bone and hepatobiliary tissue. It's a useful marker for cholestatic liver disease and disease of the bone, causing increased bone turnover and new bone formation. The most common cause is isolated asymptomatic elevation of the alphos. Alkaline phosphatase is elderly patient in Paget's disease of bone, osteitis deformans. Paget's disease is caused by isolated dysfunction with defective osteoid formation, increased bone remodeling, and focal hypertrophy. Enlarged distal interphalangeal joints in these patients. The most commonly affected bones are skull, clavicle, pelvis, long bone. Although the classic clinical manifestations are related to areas of anatomic involvement, hearing loss due to cochlear involvement, radiculopathy due to nerve compression, Paget's disease is most commonly discovered incidentally on a routine blood test. Alkaline phosphatase levels can be strikingly elevated, often more than 10 times of the upper limit of normal. Fraction, fra- um, Fractionation of ALP would be show a predominance of a bone rather than liver isoenzyme. Lab markers of bone turnover, procollagen type 1N, propeptide urine hydroxyproline are frequently elevated. X-ray of the affected bone will show osteolytic or mixed lytic sclerotic lesion, and radionucleotide bone scan is useful to fully stage of the disease. Yes, statins, atorvastatin can cause minor elevation in the liver markers, but this typically manifests with hepatocellular pattern, predominant elevation in transaminase rather than cholestatic pattern, predominant elevation in the alpha-alcoholic liver disease is typically associated with hepatocellular pattern, classically with 2:1 aspartate to alanine. And prostate cancer with bone metastasis. Prostate cancer with bone metastasis may cause an elevation of alkaline phosphatase but will cause additional features such as bone pain or systemic symptoms, weight loss, fatigue. Also, prostate specific antigen will usually more than 4 nanogram per ml. Prostate nodularity and asymmetry may be palpable on examination. Diffuse smooth prostate enlargement is a common in older men and is usually benign. Is it adolescent idiopathic scoliosis?
Yes.
X-ray should be done. Yeah, yes. Okay. Adolescent idiopathic scoliosis refers to lateral curvature, curve angle more than 10 degree. Adolescent idiopathic scoliosis refers to lateral curvature, curve angle more than 10 degree of the spine without a specified etiology. The deformity typically presents in children than 10, age more than 10 during the periods of rapid growth. Although posture is noted, although posture may be noted, AIS is usually asymptomatic and identified during school scoliosis screening and annual physical examination. Inspection of inspection of the back may reveal asymmetry of the shoulder, scapula, asymmetry of the shoulder, scapula, and iliac crest. Forward bend test show an asymmetric thoracic or lumbar prominence. The first step is evaluating clinically spinal asymmetry. The first step in spinal asymmetry is extra of the spine, full back, posterior, anterior, and lateral radiograph confirm the diagnosis, measure the severity of the disease, curve angle, and assess the skeletal maturity. Management of AIS depends on the risk progression, degree of the skeletal maturity, severity, degree of the curvature. On X-ray, scoliosis typically progress slower with increasing degree of bone ossification. Therefore, patients are at increased risk for progression in early puberty pre-menarche. Most curves are mild. Curve angles 10 to 30 degree can be monitored clinically every 6 months. A thoracolumbar spinal brace is indicated in a child with growth potential remaining and curve angle more than 30 degree to help to reduce the progression. Surgical fixation is considered if severe curvature, if curve angle is more than 40 to 50 degree. Okay.
So thank you very much.
Okay. It's Ewing sarcoma. This patient with subacute hip pain, this patient with subacute hip pain and a light pelvic lesion on imaging has a biopsy findings diagnostic for Ewing sarcoma, the second common primary bone malignancy in children. Ewing sarcoma classically affects the long bone diaphysis in patients age 10 to 15. However, the pelvis is the common primary site. Symptoms include localized pain, warmth, swelling that may limit physical activity, walking upstairs, and systemic findings. Uh, Systemic findings, fever, fatigue often indicate metastatic disease. X-ray of the suspected ring sarcoma, there is permeative lytic lesion. There is permeative lytic lesion with an aggressive periosteal reaction. Permeative lytic lesion with an aggressive periosteal reaction. Onion skinning. MRI is typically performed and after X-ray to determine the extent of the soft tissue and vascular involvement for biopsy and surgical planning. Biopsy is diagnostic to show sheets of uniform, small, round blue cell with scanned cytoplasm, as in this patient fibrous septa separating the sheets of cells are typical. Treatment include chemotherapy as well as surgical resection with or without radiation. Okay, yes. Mm, Osteomyelitis can cause fever with focal pain and swelling. An X-ray may reveal lytic lesion with periosteal reaction. However, most cases involve the long bone, not the pelvis, and this patient lack of risk factor like uh, immunodeficiency, trauma makes the diagnosis less likely. Histopathology of chronic osteomyelitis would demonstrate inflammatory cell, necrotic bone, irregular bony trabeculae, not uh, uniform sheets of cell. Is it osteoarthritis? Okay. Okay, common control. Okay, this patient, can you hear me?
Yeah.
This, yes, this patient with extremity pain, chronic extremity pain, relieved with spinal flexion and has typical feature of lumbar spinal stenosis. Spinal stenosis due to narrowing of the spinal canal resulting in compression, resulting uh, spinal stenosis is due to narrowing of the spinal canal with resulting compression of the lumbar nerve root. Common contributing factors include degenerative arthritis of the spine, spondylosis, spondyle, spondylosis, spinal osteoarthritis, including degenerative disc disease, thickening of the ligamentum flavum, leading to mechanical narrowing and the compression. The pain of spinal stenosis is associated with lumbar or the pain of spinal stenosis is often associated with activity lumbar extension during walking, worsens pain, narrowing of the canal. This termed as neurologic claudication and can resemble the lower extremity and then resemble the lower extremity vascular claudication and obstructing the atherosclerotic arterial disease. Although this patient has pain likely reflects spinal stenosis or neurologic claudication, both spinal stenosis, neurologic claudication, and vascular claudication can be seen in older patients with multiple atherosclerotic risk factor. It can present at rest if the spine remains extended but is lessened with spine flexion, walking uphill, leaning on assistive device, often referred to as shopping cart sign. In this patient, the pattern of the pain improves when leaning on a cane, and the normal ankle brachial index, the more consistently with neurologic than vascular claudication. Okay,
You read the box.
yes. Neurologic claudication. Neurologic claudication, it is posture dependent. Lumbar extension aggravates pain, worsens pain. Lumbar flexion relieves pain. Lumbar flexion relieves pain. Lumbar extension aggravates pain. Lower extremity weakness, numbness, tingling, low back pain. And on examination, there is normal pulse, frequently normal examination, and diagnosis is done via MRI of the spine. And vascular claudication, it is exertionally dependent pain relieved with rest but not with bending forward while walking, lower extremity cramping or tightness, no significant lower extremity weakness, possible buttock, thigh, calf, or foot pain. Examination decreased pulses, full extremity, decreased hair growth, and pallor with leg elevation. Diagnosis ankle brachial index. Okay.
Thank you for the if there is no
Is it transient synovitis?
eh, well,
Okay, this patient has transient synovitis, a benign condition characterized by inflammation of the tissue surrounding hip joint. Although the cause is unknown, it is commonly occurs in children aged 3 to 8 after a mild viral illness, gastroenteritis, respiratory tract infection. As in these cases, typical presentation includes acute hip, thigh pain, limp, decreased range of motion of hip joint, decreased range of motion of hip joint. Patients tend to hold the affected hip inflection and external rotation to maximize the joint. Patients tend to hold the affected hip inflection and external rotation to maximize the joint space and resist extension and internal rotation. Children with transient synovitis are typically well appearing and afebrile and have low grade fever, white blood cell, and inflammatory markers. Yes, are here and normally mildly elevated. Ultrasonogram may reveal small unilateral or bilateral hip effusion. Treatment is supportive with non-steroidal anti-inflammatory drugs, ibuprofen to relieve swelling, and transient synovitis is generally self-limiting with an excellent prognosis. Full recovery is preceded within 1 to 4 weeks. However, a small subset of patients, less than 15%, can develop recurrence as suggested patient in the patient's history. Okay,
the 4 days of pain.
okay. Let's take our vein tendinopathy. We have already discussed it. Okay, next.
12-year-old girl practically showing elevation of
Okay, it is again AIS, adenosine idiopathic scoliosis. In the previous question, there is no risk factor given, isn't it? They only talk about the, like, if it is less than, if the curve angle is more than 10 degree, it is consistent with scoliosis. If it is 10 to 30, then
Mm-hmm.
the brace, and if it is 40 to 50, then surgery, isn't it? In the
Mm-hmm.
previous question. Okay. Okay.
Mm-hmm.
Okay. In here, like, they are talking about the risk factor. Ankylosing idiopathic scoliosis, or a lateral curvature of the spine, typically presents in asymptomatic children aged more than 20. Manifests may include a rib hump, asymmetric scapula, unilateral thoracic lumbar prominence, or on bent test. Spine X-ray is used to assess the skeletal maturity and measure the degree of the curvature. That is curve angle, to rule out the structural curve angle more than 10 degrees of scoliosis. Management of scoliosis is based on the risk of a curve progression. The greatest increase in curvature occurs during early adolescence, at the time of the pubertal spurt, after which progression slows and subsequently stops once one bone ossification is complete. Risk factors at the diagnosis are associated with curve progression include female sex, age less than 12, early pubertal status, premenstrual, skeletal immaturity, severe curvature, curve angle more than 25 degrees. Although this patient has mild scoliosis, his premenstrual status indicates that she still has remaining growth potential. Therefore, she should be clinically monitored for curve progression until the 2 years after menarche, when skeletal maturity is typically complete. Okay.
Speaking of one possibility,
Okay. This patient most likely has osteosarcoma, the most common primary bone tumor, affecting children and young adults. Boys age 13 and 16 years are at higher risk. In children, the tumor occurs most frequently at the metaphysis of the long bone, such as the distal femur, proximal tibia, proximal femoris. Constitutional symptoms such as fever, weight loss, and malaise are usually absent. On physical examination, the most common findings is a tender, soft mass. Characteristics findings include speculated sunburst appearance, periosteal elevation known as Codman triangle. Alphas and LDH are elevated from turnover of a damaged osteocyte. Higher level may correlate with adverse prognosis. Increased erythrocyte sedimentation rate is non-specific. Markers of inflammation treatment include tumor excision and chemotherapy. Although overall rate of Ewing sarcoma is the second most common cause of primary bone malignancy, the incidence also highest in adolescent male, up to 20% may have systemic symptoms. X-ray shows an osteolytic lesion with a periosteal reaction that produce layers of reactive bone, giving the classic onion skin appearance. This diagnosis is less likely due to its lower prevalence on the lack of characteristic extra. Okay, this is the secondary causes of osteoporosis, the celiac disease. If you look at the X-ray closely, then you will see that there is a bones, there is a slightly blackish area over the bones, which means there is osteoporotic changes in the bone. Normally in the X-ray it does not appear. Okay, secondary causes of osteoporosis: endocrine hyperthyroidism, hyperparathyroidism, hypercortisolism, and hypogonadism. Metabolic is calcium and vitamin D deficiency. An eating disorder, gastrointestinal, or hepatic is malabsorption, celiac disease, Crohn's disease, CLD, renal is CKD, renal tubular acidosis. Medication: glucocorticoid, phenytoin, carbamazepine, PPI. Inflammatory disorder, rheumatoid arthritis, multiple myeloma, alcohol use disorder, and immobilization. These patients, this patient has distal radius collis fracture after falling on outstretched hand. Significant fracture due to ground level fall is uncommon and often indicates underlying bone fragility due to osteoporosis. The most common cause of osteoporosis is declining estrogen level in women after menopause. That the risk is significantly lower in men, and osteoporosis in A young child or mild or middle-aged man suggest a secondary cause. Bone loss is common in patients with celiac disease, largely due to malabsorption of vitamin D, impaired absorption of the fat-soluble vitamins, resulting secondary hyperparathyroidism. Bone disease may present as otherwise asymptomatic osteopenia or osteoporosis, or as osteomalacia with bone pain, muscle weakness, and impaired ambulation. A gluten-free diet appears to mitigate, but likely does not completely eliminate the risk. Lab evaluation shows normal serum 25-hydroxyvitamin D and elevated parathyroid hormone. Alphos may be elevated, and hypocalcemia and hypophosphatemia may be observed in severe cases. Management should include adequate intake of calcium and vitamin D, using supplements as needed. Periodic assessment of bone density with DEXA. Okay. This patient described is most likely suffering from Whipple disease. Whipple disease is a multi-system disease that is characterized by multi multitude of possible manifestations. Most commonly, patients with Whipple disease present with history of chronic malabsorptive diarrhea, flatulence, abdominal distension, protein losing enteropathy, weight loss, migratory non-deforming arthritis, lymphadenopathy, and a low-grade fever. The disease may also cause damage to the eyes. The disease may also cause damage to the eye, CNS, and myocardium. Whipple disease is caused by infection the gram-positive Bacillus stropyrema whipple, but a mechanism whereby patients contract this infection has yet to be determined. The diagnosis is made with a small intestinal biopsy and PCR in patients with clinical symptoms consistent with the disease. Small intestinal biopsy shows past positive macrophages in the lamina propria and non-acid fast uh, non-acid fast gram-positive bacilli. Okay.
When it comes to the treatment,
Okay, ankylosing this patient, typical features of ankylosing spondylitis, including chronic progressive back pain and stiffness, pain relief with activity, lumbosacral tenderness, and reduced spinal range of motion. The incidence peaks in individuals aged 20 to 30, although AS has a male-female ratio 2:1 and should be considered in any patient, should be considered in any young patient with progressive low back pain and stiffness lasting more than 3 months. In a young patient with characteristic inflammatory back pain, plain X-ray of the pelvis showing sacroiliitis and can confirm the diagnosis of the AS. However, X-ray may be negative in early stages. MRI can confirm the sacroiliitis. In such cases, fusion of the vertebral bodies with ossification of the intervertebral disc and bamboo spine also suggests the diagnosis. There is a strong association of HLA-B27 and AS. However, whereas more than 90% patients with AS have HLA-B27, only 5% patients with HLA-B27 have AS. Therefore, HLA-B27 is not specific for AS, and testing for it is not necessary for diagnosis. On the other hand, demonstrating radiographic changes with axial skeleton is necessary for diagnosis. Okay. Is it AS? Sorry. Why? 3 month uh, age less than 45, 3 months history of pain. Pain in the shoulder, lots, yes. Where is the heart issue? Not that low. AS does not cause heart issue. Very rare. It looks like a S. Okay. S is S. Okay. In here, like enthesitis. Insert. The red one is the enthesitis, isn't it? The red portion of the picture. Yes. Okay. So enthesitis is characterized by inflammation and pain at site where tendons and ligaments attach to bone. So enthesitis means inflammation and pain at sites where tendon and ligaments attach to bone. It, it is commonly due to tendon and ligament stretch and can manifest as acute swelling and pain. Examination findings include tenderness at the insertion site, enthesis at the insertion of Achilles tendon, enthesis at the insertion of the Achilles tendon at the heel is often most prominent presentation. However, enthesitis can also be seen at the costosternal junction, shoulders, elbow, hips, and iliac crest, tibial tuberosity, and other locations. Chronic complications of enthesis include fibrosis and calcification. Enthesitis may occur as an isolated disorder, plantar fasciitis, but is a characteristic finding in the spondyloarthritis such as ankylosing spondylitis, psoriatic arthritis, reactive arthritis. It may manifest with isolated heel pain at the insertion of the Achilles tendon, but can also involve multiple regions, as in these cases. Low back pain that classically improves with activity, loss of spinal mobility, and peripheral arthritis are the common musculoskeletal manifestation of AIDS. Okay, okay. Rheumatoid arthritis is characterized by chronic synovitis leading to hand joint deformity, ulnar deviation of the finger, swan neck deformity, buttonia deformity. Many patients have positive rheumatoid factor and some will have painless, slow-growing or subcutaneous nodule. Enthesitis is not a prominent feature of RA. Enthesitis can be seen with psoriatic arthritis, which can lead to sausage disease. However, this patient has a history of skin problems to suggest psoriasis. Okay, Okay, it's a rotator cuff tendinopathy or impingement. Okay, this patient with subacute shoulder pain, this patient with subacute shoulder pain on abduction most likely has rotator cuff tendinopathy. Rotator cuff tendinopathy results from repetitive activity above shoulder height, repetitive activity above shoulder height, painting, sealing, and is common in middle-aged or older patients. Chronic tensile loading and compression by surrounding structure can cause micro tears, fibrosis, and inflammatory calcification of the rotator cuff tendon, especially the supraspinatus. Pain may also eman- emanate from the subacromial bursa, the tendon of the long head of biceps. On flexion or abduction of the shoulder, the space between the humeral head and acromion is reduced, causing pressure on the supraspinatus tendon and subacromial bursa. Impingement syndrome, a characteristic RCT, refers to compression of these soft tissue structure. Impingement can be demonstrated with near test with the patient's shoulder internally rotated and forearm pronated, thumb pointed toward the floor. The examiner stabilizes the scapula and flexes the arm. Reproduction of the pain is considered a positive test. Untreated chronic RCT can increase the risk of rotator cuff tear. Patients with tear typically have weakness or abduction following a fall or a minor trauma. Okay, yes. Rotator cuff impingement or tendinopathy. There is pain with abduction or external rotation. Pain with abduction and external rotation. There is subacromial tenderness and normal range of motion with positive impingement test near Hawkins candidatus. Rotator cuff tear is similar to rotator cuff tendinopathy, but there is weakness, not pain. Weakness in abduction and external rotation. At age more than 40. Adhesive capsulitis decrease active and passive range of movement. Initial painful phase followed by more than stiffness or pain. Biceps tendinopathy, there is anterior shoulder pain, AB, anterior shoulder pain, pain with lifting or carrying or overhead reaching, weakness less common. Biceps tendinopathy, there is anterior shoulder pain and glenohumeral osteoarthritis, usually, uncommon. Glenohumeral osteopathy, uncommon and usually caused by trauma. Gradual onset and anterior or deep shoulder pain, decrease active and passive abduction and external rotation. Okay, can we stop
Basically,
here?